The broadcast is now starting. All attendees are in listen-only mode.
You who are on the road must have a code that you can live by, and so become yourself, because the past is just a goodbye. Teach your children well, their father's hell did slowly go by, and feed them on your dreams, the one they picked, the one you know by. Don't you ever ask them why, if they told you you would cry, so just look at them and sigh, and know they love you. That your elders grew by, and so please help them with yours. They seek the truth before they can die. Teach your parents well, their children's hell will slowly go by, and feed them on your dreams, the one they picked, the one you know by. Don't you ever ask them why, if they told you you would cry, so just look at them and sigh, and know they love.
Good morning, buzzards. I know you heard this line before, but that group was one of my favorite groups of all times. Crosby, Stills, Nash, and Young. They added Neil Young not at the beginning, and he was a really great asset to the group. He's gone a little bit crazy lately these days, but this was the biggest, or one of the biggest groups of what we called the troubled times, the Vietnam era, 60s and 70s. Now we don't realize that these so-called troubled times of 40 years ago are probably not nearly as troubled as we are now. But anyway, I'm Dr. Minarsik, and today is March 31st. It's the last day of March. Thank God. You know, March is supposed to come in like a lion and come out like a lamb. Well, we've only had 2 lamb days so far this month, and one of them was yesterday. So I hope that now that April will be tomorrow, we'll see a hell of a lot more lamb days where I could go hiking. Today is Thursday, it's 9 o'clock, and today is the second webinar on central nervous system, of which there will be about 6. And we'll talk today primarily about what we call strokes, or CVAs, as well as the classical or common central nervous system infections. This is our 50-second webinar. I think we'll wind up doing a total of maybe 62 or 63. And that's it. How about if we drop this guy, because I don't have anything more introductory to say, and let's get going. We could probably start out by, popping up to number 60 on our PowerPoints. and say that this is going to be our first big topic, one of the most common, significant conditions of the central nervous system that many of your patients, and maybe you will be subjected to during your long life. Stroke, another word for it is CVA, or cerebrovascular accidents, and it's a vascular problem, usually acute, with the brain and technically spinal cord, because that's central nervous system too. And there's two kinds of stroke anatomically or pathologically speaking. One is when the blood vessels are extremely narrowed or thrombosed by a clot, and the other is when the integrity of the arterial blood supply usually is compromised and the wall ruptures, or perhaps an aneurysm ruptures. So we have both the ischemic and the hemorrhagic strokes. As you imagine, this one is a lot bloodier than this one. Okay, but in both cases, what we have is significantly reduced blood and sugar and oxygen, to the brain. And generally speaking, strokes are regional, okay, or focal. Technically, a global stroke would result in immediate death, wouldn't it? But in the acute phase of the stroke, we're talking about days. These are going to be no surprises. We've talked about this many times. You would get edema. Okay, we're talking about a ischemic or thrombotic stroke now. And if you remember, we said that just about all types of cells will have microvacuolization when they're dead or dying. So the neurons are no exception. The neurons, or the nuclei of the neurons, and the other cells which support it, of course, will become shrunken and will become darker, and they will start to break up, and then they'll dissolve. So pycnosis, karyorrhexis, karyolysis. The first cells generally to enter this necrotic tissue are neutrophils, but in the chronic phases and in the stages between acute and chronic, the macrophages come in to chew up the dead tissue, and then more chronically, they are generally replaced or joined by the various glial cells. And remember, the primary glial cells are derived from macrophages, and those are the microglia. Okay, there is no significant influx of oligodendrocytes or astrocytes or ependymal cells. When we say gliosis in a CVA, we're primarily talking about microglia. Similar situation in a hemorrhagic stroke, the same general product, reduced blood, oxygen, sugar. And this is basically because of rupture rather than thrombosis of aneurysm. So this is why it's called hemorrhagic. Okay. Now let's take a look at the distribution of the three big cerebral arteries. There's the anterior, the middle, and the posterior. From looking at the brain laterally, it's almost the entire large, 80% of the lateral surface is supplied by the middle cerebral artery. That's the big one. Now, even though the anterior cerebral artery is called anterior, it really does go almost to the posterior or occipital aspect, but it goes parasagittally, both laterally as well as medially. And the same general thing can be said of the posterior cerebral artery. It's basically posterior, but it supplies basically the outer aspect, okay? And here, we'll take a look, and maybe this will even be more obvious to you. There's anterior. There's middle. There's posterior. And there's anterior. Look how far posterior anterior goes now. Now let's take a look at the brain from another slice. Now we're basically cut it in half, and most of the medial aspect of the brain, the parasagittal, let's say, is not anterior, but it's the remnants of the posterior as well as the anterior. There's very little middle from this view, just a tiny portion of that lobe over there. So let's say we had a classical thrombotic middle cerebral artery CVA or stroke. Okay, so you know from these slices, it's not going to involve the medial aspect of the hemispheres, but large portions of the lateral aspect, including, the basal ganglia, which is supplied by the middle as well. And it might look something like this. And I know what you're thinking. You're thinking, well, if this is thrombotic, why do I see all this blood? This is not entirely blood. This is basically edematous tissue. And of course, edematous tissue, dead tissue, can result in some blood leakage as well. But this is not a hemorrhagic CVA. This is a thrombotic CVA. So this is discoloration mostly due to edema and necrosis. But let's say we had a hemorrhagic anterior cerebral artery. Well, remember, we said that very, very much of the medial aspect of the hemispheres would be bloody. Now, this is not questionable as to whether it's blood or not. This is a big blood clot. This is probably even what you would call a hematoma. And it is going pretty far, even posterior, okay? But basically, we're talking about not the lateral convexity, but the medial portions of the brain. So I think that's a pretty example of a hemorrhagic ACA versus a thrombotic MCA. And these are all fairly much in the acute stages. But of course, everything progresses in pathology. So if you want to talk about propagation or evolution or progression of infarcts, you could probably say in the very early stages, with lack of blood supply, the tissue becomes edematous, okay? And then very shortly thereafter, perhaps within hours or days, you could say, well, a lot of these neurons, the neurons are the big cells, look a lot redder than they shouldn't be. Shouldn't they be blue, and here they are red? Well, these are the so-called red neurons, which is a non-specific indication of neuron injury and death. Because this is now dead tissue, this is, of course, a stimulus for the neutrophils to come in. You could see them here entering from a vessel and starting to pepper, the dead tissue. Within a few days, the neurons would be primarily outnumbered, perhaps, by the macrophages and perhaps early gliosis. And the reason why you see this here is because basically the macrophages are chewing up the dead brain tissue. Finally, now we're talking chronic. Of course, the neurons do not regenerate, but chronically, a lot of this acute inflammatory debris that you see here and here clears up, and it's just replaced by gliosis. And if you remember, this is really not different at all from the changes we talked about. When we talked about acute and chronic inflammation of anything, we're talking edema, neutrophils, macrophages. And then the chronic inflammatory cells that we saw of chronic inflammation, okay, are now in the central nervous system called gliosis. And in a way, they still are the chronic inflammatory cells because they are the glial cells, most of which are derived from macrophages. So there's your histologic, pathologic progression. Okay, now we can't ignore the fact that besides thrombotic CVAs, we also can have hemorrhagic CVAs, okay? Now, is a hemorrhagic CVA, could it be caused by hypertension? Yes. Could it be caused by, let's say, just rupture of a weakened artery without significant hypertension? Yes. Could it be caused by a rupture of an aneurysm of an artery without significant hypertension? Yes. But generally speaking, the more pressure you put in an artery, more likely you are to rupture a weakened portion of an artery from any reason, atherosclerosis, inflammation of the artery or arteritis, or an aneurysm. Now, let me tell you a little fact which you may or may not know. Let's say that I took you and I increased the pressure of blood inside your brain. Normal people. And we kept increasing and increasing and increasing and increasing that pressure. Well, don't you think at some point we would have rupture of those arteries? Yes. Now, anatomically speaking, the arteries of the brain that are the most sensitive to hypertension, if you remember those are the lenticulostriate arteries, and they supply the internal capsule and most of the basal ganglia, okay? And they are one of the first primary branches of the middle cerebral artery. So, let's make a long story short. What would you expect to see if you had a hypertensive CVA? Would it be hemorrhagic? Yes, because of rupture of the lenticulostriate arteries. Of course, any artery could rupture. Any other artery that was weakened or aneurysmal could be. But basically, a hypertensive CVA is a hemorrhagic CVA in the area of the basal ganglia. And here's your lenticulostriate arteries. Look at, it's one of the very first branches. There's several of them going to the internal capsule, to the basal ganglia, and supplying that portion of the brain. I think I have another little diagram here, which I added yesterday. I guess you could say the caudate, globus pallidus, putamen, okay, even portions of the thalamus. These are all portions that would be part of the general domain of the lenticulostriate arteries, which are the most sensitive arteries to increased blood pressure. So, here we have a brain that's cut coronally, and we see a big hemorrhagic area. Not only is it hemorrhage, but it has a mass effect. This blood, which has collected because of rupture of the lenticulostriate, has a pushing effect on the ventricles and cerebral hemispheres as well. Okay, let's see, I put a little note down here, and I'm just wondering, oh yeah. On the top, you could see hemorrhagic areas. No doubt this is blood. No doubt this is a lot of blood. No doubt this is a red, purple, blackish hematoma. But let's say you're looking at areas and you're not really sure. Yeah, is this a little redder than usual? And is this a little redder than usual? Well, I want you to remember something. The most sensitive sense that you have for examining brains grossly is not necessarily your eyes. It could be your sense of touch. So things that might look normal, like, I could show you this and you could say, hey, those basal ganglia don't look too bad. Well, put a blindfold on yourself and start palpating it with your finger and compare it to the other side. Does it seem a little softer? Does it seem a little mushier? Because edema is very often more accurately detected from the sense of touch rather than the eyes. Okay, now this is perhaps edematous. I don't know if you could say that's early hemorrhage or not. Maybe you can. In this case, you could say it looks like there is some type of slit-like hemorrhage within here. So that wouldn't be too much of a problem. So I use the word slit, and let's get into that a little bit more. Also in this basal ganglia area, you can have what they call lacunar infarcts. Okay, and those are small infarcts, and they're generally related to primarily hypertension, like most of the strokes in this area is, but they're very old and they may be asymptomatic as well. And the reason why they call them lacuna is they're very small, perhaps a millimeter or so. There's one over there, there's one over there, there's one over there. It's not terribly unlikely that if you have an elderly patient that never had a stroke and you did a CT or an MRI, which can also detect these small pinpoint circular lunar infarcts, that they may have them and never even know that. And that was the case with my father. He had small lacunar infarcts, but he never really had a history of a stroke. Now in this area here, I think you could see perhaps it's getting a little redder, and perhaps there's even going to be like a linear type of black area, or what they would call a slit hemorrhage. And these are also very popular for small CVAs, especially hypertensive CVAs in the region of the basal ganglia. Here's another slit hemorrhage, which is pretty much more obvious over here. And that's definitely hemorrhagic. And I think this might be the exact same picture that I showed you when we were looking at this as well. Okay, so seems like we talked about a lot of strokes, thrombotic, hemorrhagic, hypertensive, which are usually hemorrhagic. But what about the changes that you might see, perhaps not exactly in the brain, but perhaps in the region of where the arteries congregate themselves? So, if a artery ruptures in the middle of the brain, you're going to have intracerebral or intraparenchymal hemorrhage. But what if there's a problem of a rupture, either hypertensive or a weakened artery or aneurysmal, before it enters the brain? Well, what do you have before you enter the brain? You have the subarachnoid space, don't you? So let's talk about subarachnoid hemorrhage, okay? And that would be classically rupture of the large intracerebral arteries, which are the primary and secondary branches of what we used to call the circle of Willis. I notice now the anatomists want to call this the anatomical circle, but it doesn't matter. Or this is also the primary place in the basal subarachnoid region for a berry aneurysm. And when I show you a picture of something that looks almost exactly like a blueberry, you'll probably know why they're called berry aneurysms. But don't forget, it's probably just as likely or more likely that an aneurysm wall could be weakened or the artery could be weakened and aneurysmally dilated simply from weakening of the wall through atherosclerosis. But an aneurysm that is congenital is generally not related to atherosclerosis. And they're also more likely to be circular rather than fusiform. That's another type of adjective that are used for aneurysms as well. I can't resist the temptation to tell you a story or a fact, let's say. Let's say you're a coroner or medical examiner and you have a perfectly healthy young woman that never had any disease in her life. And she's walking down the street. And she's as healthy as could be. And then, boom, she drops dead instantly. Well, when you take that woman to the medical examiner's office, he's going to say, let's go look for the berry, okay? Because sudden rupture of congenital or even atherosclerotic aneurysms in the older age group is a very, very common cause of unexplained sudden death in the absence of previous illness. So here's where the berries grow. You might remember this is your so-called circle of Willis. Internal carotids, you could say, are one of the main places. Anteriorly come the anteriors, and then there's an anterior communicating, and then you have the posterior communicatings coming down to the posterior cerebral artery. And look, about half of them are in the region of the anterior communicating or the anteriors. Another large group is usually in the first branch of the middle cerebral, but there's also a bunch where this middle cerebral comes off or joins with the internal carotid. And then a few of them are basically at the bifurcation of the basilar artery. But if you remember, if you take this as the center of the anatomical circle, basically 90%. I didn't add these up, but they must come out to like about 100%, 40, 60, 90. Yeah, it's about 100%. Almost all of the aneurysms, the berries, are at the bifurcation of major arteries of the circle of Willis. And if you want to speak distance, probably within 1 inch of the circle of Willis is where all of your congenital Berry aneurysms are. And also, if they're congenital, they're more likely to be circular. The atherosclerotic aneurysms, of course, can be circular, but they have more of a fusiform configuration. Here, I have a nice picture here. Now, if this wasn't a pathology specimen, and I just took this out, you would probably think it was a blueberry, wouldn't you? It has that same color, and it's very spherical. This is a classical congenital Berry aneurysm. Now, could it be an atherosclerotic aneurysm? Yeah, it could be. Okay, but this is why they call them berries. And of course, because we're talking about arteries that are in the basal or the base of the brain, the superior and lateral portions of the brain also have a subarachnoid space. But why is it that most of the Berry aneurysms and subarachnoid hemorrhages are at the base of the brain? Because that's where the arteries are the largest, okay? So here we go. We got your finger there approximately in the middle of circle of Willis, and almost all of the hemorrhage is around that as well. Could this hemorrhage dissect into the brain? Of course it can, even though it's primarily subarachnoid. Here, let's ask you another anatomic question. Could the hemorrhage in the brain itself dissect into the subarachnoid space? Of course it could, okay? So let's go on and talk about the clinical features of a hypertensive encephalopathy, okay? It's not just kidneys that your doctor is worried about when he's treating you for hypertension. It's also for, CVAs as well. So, in order of severity, the earliest sign of a hypertensive encephalopathy would be a headache. And even though I gave you the example of a woman who's perfectly fine and boom, she drops dead, statistically speaking, she's more likely to have a severe headache before she drops dead, okay? If that progresses, she basically is confused, has a lot of anxiety, and remember, this is in increasing order of severity. Finally, very often possibly as a pre-terminal event, convulsions might occur. That would be a significant progressing hypertensive bleed, okay? Chronically, she could wind up having other infarcts of the brain, hemorrhagic or otherwise, and have a condition called MID, or multi-infarct dementia. So even though most dementia might be caused by a degenerative or Alzheimer type of brain disease, very often patients with chronic hypertensive encephalopathy can present like Alzheimer's disease as well. And of course, if the primary area for most hypertensive bleeds or strokes or encephalopathy are in the region of the basal ganglia, what are some of the classical basal ganglia symptoms? Well, I've highlighted about 5 of them over here, and perhaps some of them are easy to understand, and some of them I might recommend you actually go onto YouTube and look at some of the movies. But everybody knows what the tremor is, okay? It's basically a rhythmic oscillatory movement, like with Parkinson's disease. Or athetosis, which is a slow writhing movement. Some people call this like a snake-like movement. When the snake-like movements become a little faster or more abrupt, that's generally called chorea. And these are all classical symptoms which are often attributed primarily to basal ganglia disease. Now, bullism is also a very rapid, but it's like a flailing or throwing movement. When you think of bullism or hemibullismus, which is on half of the side, think of a pitcher throwing a ball. Look how fast that arm throws the ball. And then another more difficult to define symptom called dystonia. And it's a persistent posture of the body which can result in grotesque movements. Now, I know that's easy to say in words, but it's hard to really define that. Last night, I spent about a half hour looking for classical dystonias. And I was not successful. So I think we're just going to have to keep it as a persistent posture in a body part, like an arm or an extremity or a neck, okay, that can result in distorted, grotesque movements. That would be what the neurologist would call a dystonia. Okay, should we take a break? It's early, but we're going to spend a significant amount of time talking about infections now because we've covered the topic on CVAs or strokes, and now we'll talk about infections. I'll tell you what, let's just do the definition. It's still very early. This will probably not be a long webinar, but let's talk about the various patterns of infection. Okay, well, don't forget the central nervous system has to include the meninges, so an acute meningitis. Or you could have, rather than a inflammation, an acute inflammation, classical acute inflammation, only involving the meninges, it could be primarily localized to one area, focal, and also suppurative, which means pus, right? So these are basically the brain abscesses. Of course, you have a category of the chronic infections, and they are generally cerebral rather than meningeal. Most of the viral infections are maybe localized, but they primarily involve the brain rather than the meninges. Although when a CNS brain infection, whether it's viral or anything, spreads to the meninges, it might be called a meningoencephalitis. Furthermore, if you have an acute bacterial meningitis extending either grossly or microscopically into the brain itself, that also might be called meningoencephalitis. Okay, so depending on which way it's spreading, and it basically has the same word. In immunocompromised people, generally, we have a variety of deep fungal infections, which, if you remember, are basically granulomatous. And then I'm going to throw in a bunch of other 5 or 6 little examples of things that can involve the brain in one of these patterns. And we'll deal with that. So this is going to be our next big primary topic, and it's only 9:30. So how about if we take an early music break, and I guarantee you we're going to probably have one of the shortest webinars you've ever imagined or perhaps ever hoped for. So let's play another one of my classic rock things, and we will see you in maybe 10 minutes or so. So here we go.
I close my
troubles come and my heart burdened be, then I am still and wait here in the silence until you come and sit a while with me. You raise me up so I can stand on mountains. You raise me up to walk on stormy seas. I am strong when I am on your shoulders. You raise me up to more than I can be.
comment that You Raise Me Up is one of their favorite songs. Well, I got news for you. It's mine also. Not only do I like the rock and roll classic junk rap and country and stuff, but I really like the spiritual songs as well. I had two thoughts when I went out for this little mid-time break. And I don't know if they came together or if one came before the other, but I have to tell you, the first thing I kind of felt was guilt. Because here we are, I discussed about half of what I wanted to talk about, and it was only like a half hour. And I thought, oh my God, maybe this webinar will only be 1 hour long rather than 2. And maybe I'm cheating somebody, but that's a crazy thought, because really deep down inside, when you have to make a presentation, never, ever, ever, ever gauge yourself by a clock. Just say what you have to say. And that leads us into the second thought that I had. And I guess you could say it was a thought about pictorial demonstrations or graphic demonstrations. Pathologists love to teach because they can show a lot of pictures and then talk about each one. And that's basically what we're going to do in the second half. Usually in the beginning of the webinar, I give you a little summary of what it's going to be like. Sometimes I say it's going to be horrible. No, but this one is one of my favorite ones also. But the fact that you could just show pictures and talk about them, I think not only do I love it the most. Now, whether you like that or not, I don't know. I don't think there are many people that want to see strings of PowerPoint bullets all the time. But I really, truly believe that it's the best way to teach as well. So now when we talk about CNS infections, we're going to go into a lot of pictorial, beautiful pictures and maybe say a few words about each one, maybe more than a few words. But there's a bunch of pictures we're just going to go over pretty quickly. So let's do it. How about if we go back to the PowerPoints? We talked about the general anatomic or histologic patterns of brain or CNS infections. So let's talk about infections in general. If you think of infections as basically mostly being bacterial or viral, that's one way to group them. But a general principle or a general rule within it has a good number of its exceptions. And I'm not sure if you knew this, but most meningitises or meningitis, if you like that word, are generally bacterial. Yeah, there's some exceptions to the rule. Now, most encephalitis is generally viral. Okay. Now, of course, if a meningitis is severe and it spreads into the brain, you could call that a meningoencephalitis. If an encephalitis, generally viral, is severe and spreads to the meninges, you could still call it a meningoencephalitis. Okay. And of course, there are even things like infections of the meninges that are secondary to chemical or toxins or tumor metastases. But generally, we'll be talking about primary infections by the usual critters: bacteria, viruses, fungi, and then maybe even start out with one of the most curious critter of all, called a prion. Well, there's a meningitis, okay? It's the meninges, it's the leptomeninges. The dura has been stripped off. But do you notice how it's yellowish, okay? And it's probably more on this side than on this side. Now, the word that is used in the neuropathology reports is cloudy. In fact, when you get a neuropathology report, they usually start out by saying the leptomeninges are clear. Well, these are not clear. They're cloudy, they're yellow. And why do you think they're yellow? Because if they're acute and if it's bacterial, this is pus, isn't it? Okay, so that's the reason for the cloudiness or yellowish discoloration. Here's another picture now looking superiorly over the convexity. I think you could see that this area is cloudy and more yellow than the normal, more peripheral parts, and same here. So this is a bilateral, which covers meningitis, acute meningitis, and it's mostly bacterial, generally speaking. Microscopically, you know that these are the vascular meninges. You can see that they're just loaded with these inflammatory cells. You can see the inflammatory cells have significant amount of cytoplasm. So instantly, before we go to high power, and of course we can't go to high power with a still picture, these are neutrophils. You know, it's suppurative. This is why it's yellow. This is why it's cloudy. And that's why you can't see the underlying gyrus very well. Now, let me ask you a question. This is a pretty significant meningitis. It's not just 2 or 3 neutrophils having lunch at the same table. This is loaded with neutrophils. So can I ask you, it's a rhetorical question, do you think that that might have resulted in some of these superficial cortical layers also having an increased cellular inflammatory response? In my opinion, yes. So if you wanted to call this a meningitis, you'd be 100% correct. If you wanted to call this a meningoencephalitis, I wouldn't argue with you on that one either. And vice versa. Let's say these meninges were perfectly clear, but the brain was loaded with inflammatory cells because of some viral or other type of encephalitis. And it also involved the meninges. Well, that would be a meningoencephalitis too. Okay? I don't think I showed you a very important slide, and it's this one. When I told you that meningitis were generally bacterial, okay, in neonates, when meningitis might break out in neonates, the most common type of bug, bacteria, would either be E. coli or strep, okay, strep B. In children under age 2 with a meningitis, it's regarded as Haemophilus influenza until proven otherwise. Most of them are. In the so-called adults now, the so-called infectious or contagious type of meningitis, you know, it's the gram-negative cocci Neisseria meningitis. That's the bacterial cause. In elderly people, okay, it's still bacterial. It's still acute. It's still loaded with neutrophils, and that's a strep or perhaps a listeria. A meningitis would, of course, have a lot of neutrophils or polys or PMNs when you do the spinal tap. There's increased protein. Why? Because an acute inflammatory reaction generates a variety of proteins, okay? And why is there reduced glucose? Well, maybe there's a lot of reasons you heard, but think about it. If your meninges are loaded with bacteria, they're probably consuming your glucose. So these are the features in your spinal tap when you send the cloudy fluid to the lab. In encephalitis, the arboviruses by far are the biggest family, but practically all the major types of herpes virus, HSV, CMV, VZ, these are also very, very common encephalitis, perhaps as much or maybe even more sometimes than the arboviruses. Polio, you know, is a viral CNS infection. Rabies, HIV, is not only enabling opportunistic organisms to infect the brain, but the virus itself, the human immunodeficiency virus, is also a direct cause of a common type of encephalitis seen with AIDS patients. And of course, even though I'm going to show you a big list of all the various viral critters that could infect the brain, and you might be confused or your head might be spinning, just remember, in almost all of these different viruses, the histopathology is very, very similar. And I'm just going to give you about 4 words here to remember. They talk about mononuclear, so that means lymphs or macrophages, cuffing the blood vessels. They are in the perivascular spaces. Now, in the brain, the perforating arteries of the brain, okay, there is a theoretical space called the Virchow-Robbins space. The reason why I love this term is because Virchow is the father of pathology, and Robbins is the father of pathology education. And that's basically the textbook that I've been using for, 15 years now as my source for almost all of my lectures. And I even stole a few of their pictures too. At first, the publishers were kind of mad at me, and then Dr. Kumar said, hey, wait a minute, why should you sue this guy? Because he's probably selling more of your books than any of your salesmen are. So they left me alone. In fact, last year, Robbins publishers, which is Elsevier, they asked if they could even use my PowerPoints on their website. So I'm thrilled. And of course, once again, meningoencephalitis, which means both areas are involved, either from a primary meningitis or a primary encephalitis. So let's talk about the second type of inflammatory pattern. They're still acute. It's still primarily neutrophils. That's what an abscess is, isn't it? It's a big localized area of neutrophils. Now, that means they're probably primarily bacterial as well, doesn't it? What happens if you have a severe infection in your mastoid sinus, if you remember anatomically, very close to the brain, or even in any of your regular paranasal sinuses? What if there's a whopping acute infection there? Could it break through and enter the brain? Yes, it can, okay? But you can also have a cerebral abscess from things like subacute bacterial endocarditis, where you're showering, bacteria basically all over your body. Maybe a tooth extraction might be a classical scenario, or general sepsis for any bacterial inflammation. And once again, most of the cerebral are bacterial, whether they're local or hematogenous. And of course, they're usually staph or strep. And pathologically, you're going to see pictures grossly and on CT that very often, not only are they very localized, but they can be kind of separated from the rest of the brain by having a fibrous capsule, which gets thicker and thicker the more chronic the abscess is. Okay, in the sinusitis abscess, the basic collection of pus is subdural. And why is that? Because the sinusitis infection actually can generally perforate or involve the dura and cause a collection underneath it. Now, in the epidural abscesses, like with bone osteomyelitis, you have an infection in your bone, and it's generally limited to the bone. It doesn't perforate the dura, okay? But if you remember, the highest portion of the dura is also the periosteum of the bone. But in the epidural abscesses, usually secondary to skull trauma, very often surgery. It's the neurosurgeon's number one concern when they start chipping away at the bones in your spine. The abscess is usually epidural rather than subdural, like you usually get with severe sinusitis. Here's a abscess of the brain. The radiologist will instantly tell you this is what they call a ring sign. Because, yeah, you have a localized collection of something, perhaps not quite the same MRI signals as the rest of the brain, but it has a rim around it. And by the way, this is not MRI, this is CT. So it is obvious that the fibrous capsule of this liquefied or abscess type of center is probably denser It's not as dense as the bone of the skull, obviously. And look, there's even a little satellite lesion there, isn't there? These are all classical examples of CT brain abscesses. If I said MRI at the beginning, I was wrong because I think I have another picture. Here's the gross specimen. Same general process. A very significant portion of this hemisphere has a space-occupying lesion. The space-occupying lesion, which is an abscess, has a more dense fibrous capsule around it. And this is not obvious in the early stages of the abscess, but as it gets organized, you'll have what you would normally get, an inflammation, an area of increased vascularity or granulation tissue, and finally at the very periphery, a more dense fibrous capsule. So let me ask you a question. Whether you're a pathologist looking at this at autopsy or you're a radiologist looking at this on CT or MRI, let me ask you this. All you really see here is something that's less dense and irregular and maybe necrotic, but not quite as firm as the surrounding capsule. And we call this an abscess. But here's the question. Could it be a necrotic high-grade tumor that's also necrotic? And the answer is yes. So that's why when the radiologist tells you that the ring sign is not just for abscesses, they could also be high-grade primary or even metastatic brain tumors. You know, the primary ones would be a high-grade glioma or a glioblastoma multiforme. They could give this similar appearance, both radiologically as well as grossly. Of course, microscopically, it's like any abscess. It's just nothing but neutrophils or pus cells and fibrin. And look at it, there's even a nice blood vessel over there. So if I told you this was an abscess from anywhere in the body, you'd probably have to agree with me, okay? Here is a brain. Here is an abscess. Here's the dura over here. And this abscess has become subdural, even though it still has a little capsule around it. And this is a subdural empyema. Empyema is basically another word for abscess, whether you're dealing with the brain or the lung, okay? And this is probably secondary to sinusitis, maybe a mastoiditis or some other type of sinusitis. Here is also the central nervous system, you know, the spinal cord in this case, and we have an epidural collection of pus. Now, why would that be? Well, most of the epidural abscesses are secondary to surgery, usually, or trauma to the bone. So think about it. If you have trauma to the bone, it'll involve primarily the bone, and maybe an osteomyelitis. But it stops short of the periosteum and dura, so it doesn't dissect into this portion of the central nervous system. You want to make a long story short? Epidural, bone infection, subdural, sinus infection. And I hope I explained the reasons clearly. Okay, now here's another section through a brain. I'm not too sure exactly what level this is, but you do see what look like some residua of basal ganglia here, maybe ventricles, and you see what you would normally think must be some kind of tumor because it's not hemorrhagic. And look, it's pushing and widening the brain and the ventricles. This is actually a tuberculoma, you know, like bone, like lung, like anything that's involved with tuberculosis. The granulomas can be significantly large and behave like tumors. In this case, look what a tremendous pushing margin it has. This might as well be a primary brain tumor, but it isn't. It's just a large tuberculosis granuloma. what about viral encephalitis or bacterial encephalitis? I started out by telling you that most of the encephalitis is viral and most of the meningitis is bacterial. Now I have to show you one of the obvious exceptions to the rule. This is Lyme disease. This is what they call neuroborreliosis. Well, you know what causes Lyme disease. It happens to be the #1 vector disease in the United States. And here's the name of the tick. Okay, it's in the Ixodes family. They also call them the deer tick or the black-legged tick. Okay, and that bugger, if he bites you and that head is under your skin for not instantly, but usually a few hours, when they bite you, when they burrow, they don't instantly release their bacteria. But here is the spirochete bacteria. This is a little guy called Borrelia family, okay? And this is the spirochetal bacteria that produces Lyme disease in various places. And the brain is no exception, okay? Of course, this would probably be an acute case, and this is one of the possible sequelae of Lyme disease. And you could see it's an encephalitis. Even though it's a virus, it's not producing much of a meningitis, but an encephalitis. So you see those little edematous gliotic areas within white matter, okay? That's encephalitis. Actually, I never knew anybody that had it, but my nephew's dog was bit by ticks, and he became crazy after about a week, and they correctly diagnosed it. They put him on the antibiotics, and he was a nice little doggy again after, a few more days. Okay, and I had acute Lyme disease too, but I don't think it made me crazy. I don't think it involved my brain, and I was okay after a couple days too. Okay, so here's the long laundry list of the various viruses that are primarily causing an encephalitis, and they've added the word meningoencephalitis, but if it's early stages, it's primarily brain white matter encephalitis. This whole family of arboviruses. Now, arbo is not a genus or a species. Arbo means arthropod born. So even though this is a variety of different species, like West Nile virus, equine encephalitis, Venezuelan encephalitis, and a whole long laundry list of other ones, the thing that they share in common is not a family or viral type. It's the fact that they're all delivered to you by various arthropods. So that's probably the single biggest one, and that's the top of the list. But look at the next four. Herpes simplex 1, herpes simplex 2, the classical genital variety, varicella zoster, CMV. These are all viruses within the herpes family. And probably together, they probably represent probably about as many cases as the arboviruses themselves. Polio is a virus, rabies is a virus, HIV is a virus, and not only does HIV enable opportunistic viruses, like CMV, for example, or toxoplasmosis or whatever, but the virus itself can cause a meningoencephalitis, not just by virtue of the fact that it's weakening your immune system. Another less known type of virus is called the JC virus. Produces a disease called PML, for progressive multifocal leukoencephalopathy. Well, leukoencephalopathy means white matter of the brain, and it's multifocal. And progressive means it's progressive. And in the old days, for throwing in a historical note, measles, everybody had measles. I had measles. And then the vaccine basically wiped measles off the face of the earth. But when the children died from measles, they just didn't die from pneumonia. Many of them died from an encephalitis in a syndrome called subacute sclerosing panencephalitis. Now, even though I may have your head spinning a little bit now by this big, big laundry list of viruses that can infect the brain, I'm going to relieve your anxiety because I'm going to tell you no matter what virus it is, it usually starts out as these lymphocytes cuffing that little space around the perforating brain vesicles, perforating vascular vessels, usually arterioles, okay? And that's called the Virchow-Robbins space. So that's a really good example. And here's another really good example. But even, you can see in multiple areas here, you have what look like our prominent perforating blood vessels. But if you look at them closely, they all have lymphocytes cuffing them. So, if you can't remember this, that's okay. But the thing you must remember is that no matter what type of viral encephalitis you're dealing with, it starts out at first perivascular lymphocytic cuffing in the Virchow-Robbins space. Okay? And another tip you should remember, one of the common types of encephalitis that's caused by herpes, whether it's HSV1 or 2, it usually involves the temporal lobes, and it often is bilateral. So, if you went to a neurologist and you had symptoms of a encephalopathy, and he did an MRI, which shows these light areas because there's edema and inflammatory cells or gliosis, whatever, and he sees a bilateral temporal lobe encephalitis, he's going to tell you even before he might send portion to the lab, maybe a biopsy, and they see these little viral particles, which are classical for herpes simplex. So, long story short, bitemporal encephalitis is HIV until proven otherwise. Here's a nice picture now, not just of this area here, but you can see the temporal lobes are hot or have increased signals because they are edematous, which means they have increased water, which means they have increased protons from the H2O. And now you're looking at it in the neuropathology lab. And once again, you might say, well, this part of the brain doesn't look too bad. And, I'm not really sure if there's anything wrong here either. Maybe this is a normal brain. Well, put on your damn blindfold and forget your eyes. And now just rub your fingers over this part of the brain. It's a little bit firmer than this mushier part of the brain in the temporal lobes, isn't it? So once again, that's another example of how, at least if you're a neuropathologist, you have to realize that your fingers are more sensitive for edema than your eyeballs. And of course, the most sensitive thing of all is the MRI scan, because you could do what they call a T2 weighted image and really, really enhance that edema because of the fact that there's increased water and therefore increased protons there to spin. A couple of other examples without going into a lot of details. Here's an encephalitis in which you see an intranuclear basophilic inclusion. Well, any inflammation, suspected viral inflammation, where the nucleoli or the nuclei have basophilic inclusions is probably CMV. Now, herpes simplex and herpes zoster, the nuclei is usually red or eosinophilic. But now remember, this is not the virus. This is a cell that's infected, okay? An infected cell with a basophilic intranuclear inclusion in a viral infection is CMV until proven otherwise. Now here's another viral type caused inclusion. This is not the virus. This is a cytoplasmic inclusion inside of a neuron. There's the nucleus of the neuron. there is a red now, not a blue, but a red eosin inclusion. And this is a classical Negri body of rabies. And even though they call it Negri, it's not black, it's red. Okay, let's move on. I think I'm going to have a nice picture for you here of HIV encephalitis. Now, don't get into the habit of thinking that HIV just weakens the immune system for other viruses and bacteria, because in this case you actually have the virus itself causing an encephalitis, and you can see it's primarily in white matter here, isn't it? In fact, sort of like periventricular white matter even. And here's your classical viral type encephalitis picture with a lot of these lymphocytes surrounding the blood vessels. But look! Around the blood vessel, you might see that some of these cells might look like they have multiple nuclei in them. In other words, like multinucleated macrophages. Here's the best picture of all, which I put in the corner, and I'm going to pop it out for you. Here's a perforating blood vessel. Here's inflammatory cells around it, like any regular old. But in HIV, you have these multinucleated cells surrounding it. Now, I'm going to tell you there's other viral infections where you could have multinucleated cells. But in a patient where you have the slightest suspicion of HIV and you have a brain blood vessel with surrounding multinucleated cells, you got to think, well, that's probably the virus itself. Okay, another viral disease, okay, is called PML. And encephalopathy means it's primarily not only brain but white matter. That's why it's called leuko. It's a progressive disease. It's multifocal. And here we go. That JC virus, or JC polyoma virus, is the actual cause. And because it's in white matter, which is basically an area that has a lot of myelinated fibers, the virus itself primarily affects the cells that make the myelin in the central nervous system. In other words, the oligodendrocytes. So, if everything I said so far is the setting for the disease, if you have a virus that in the white matter primarily affects the cells that make the myelin, then this picture is going to look like it's a demyelinating disease. I think I have a couple of really nice pictures here. Well, all you can see here is that there's edema and maybe gliosis. Okay, you don't know itself if this is demyelination. In fact, whether you're on CT or MRI, this happens to be MRI, but whether you're on CT or MRI, you see something bright. There is no signal that is specific for demyelination. There's signals for edema, but in this case, the reason why it's bright is not because of the demyelination here and 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 here. It's because of the edema that is associated with the demyelination. In fact, let's go through this again. We mentioned this twice or three times already, but if I have to say it 10 times, it's one of the key features of all of neuropathology. Whenever you have demyelination, you're probably going to have edema and gliosis. Okay? When you have gliosis, it's probably associated with edema and maybe demyelination too. Whenever you have edema, it might be associated with demyelination and gliosis. Not 100% of the time. So those three things together, what I call the neuropathology triangle, are non-specific changes in alerting you to a wide variety of degenerative and inflammatory and even neoplastic diseases of the central nervous system. what is this? This is gliosis, isn't it? You might not appreciate the fact that it's associated with edema. You might not see the gliosis itself on MRI or CT, but if it's associated with edema, that means it's going to be a little bit less dense to CT, a little bit softer to your finger, and also the fact that it has more water, it's going to have increased signals because of increased H2O, because of increased H, which are protons, which you could enhance in the T2 weighted images. Here's another example of PML. If you remember, myelin is a fat, and so myelinated areas of the brain, like here, are going to be stained with a fat stain. This fat stain is a blue stain. There's a wide variety of fat stains, but if you see that there's an area, even a large area or multiple areas that don't take up this blue myelin stain, you could probably say that's demyelination. In fact, you might look at this and say, oh my God, could that be multiple sclerosis, which I heard is a demyelinating disease? Yeah, it could be, but don't forget, this viral disease also can cause widespread demyelination in the central nervous system too. Okay, remember measles? Of course you don't. You're too young for that. But I remember it because I had it and all my friends had it. But now with the vaccines, it's been wiped out. So it's not surprising that measles, being a virus, would show up as this perivascular lymphocytic cuffing. Okay, and also you can see that it's causing these areas in the brain to have these increased signals in the white matter. And the serious, even though 90% of kids with measles in the past did not die from it, when they did, it was probably because of either pneumonia. They have a special type of giant cell pneumonia, but it could have also been from an encephalitis. Something they called SSPE, for subacute sclerosing panencephalitis. That means it's very, very largely distributed in the brain. Fungi. Okay. The single most common, most likely fungus to affect the meninges and secondarily the brain is Cryptococcus. And as with all fungal deep infections, okay, it's usually in immunocompromised hosts. You see them in patients that are on chemotherapy or perhaps have other severe immunosuppression like HIV. So, without a doubt, if you have a fungal meningitis, most likely it's Cryptococcus, cryptococcal meningitis. But they also admit that it could be so significant, it could also be not just limited to the meninges, but the brain itself. So they're calling these things fungal meningoencephalitis. Crypto at the top of the list. Candida, also in immunocompromised hosts. I've seen a couple of cases of Aspergillus and Mucor in very compromised hosts as well, which would include diabetics as well. Now, when you do your spinal tap, okay, and you got that fluid inside your tube, it might look clear, okay, even if it's some type of meningitis. But did you ever wonder why they always, after you send it to the lab, put a drop of regular old India ink with parts of the spinal fluid? That's because with Cryptococcus, which is a yeast fungus, but here you can see even like a little bud from the yeast, can't you? And you can see here a bud as well. You can see that these yeast has a prominent capsule, and that capsule completely repels the India ink. So there's the cell, there's the capsule, there's the yeast cell, there's the yeast cell bud. But then look at that very, very white striking capsule around it, which makes that normally black India ink really, really, really stick out. Now, no matter why you're doing the spinal tap, it could be for metastatic disease or some other infection or whatever, hydrocephalus, okay, they're always going to probably do an India ink test as well in the lab. And here we go, Cryptococcus, multiple areas of the brain, okay, and here you could even see, the little micro abscesses that they might cause. But if you remember, like all of the fungal, deep fungal infections, the primary pattern of inflammation is usually granulomatous. So I'm sure a lot of these cells are macrophages and giant cells as well. Okay, I did this last night, not to go into the details of all these diseases, but you should remember that these common diseases that we have already talked about or will talk about in the chapter on infectious disease pathology in about another month, all of these diseases can be associated with a localized or diffuse central nervous system infections as well. Here's malaria, okay? In malaria, you could see that these are like hemorrhagic areas due to damaged blood vessels. In toxoplasmosis, also a disease of immunocompromised people, of which HIV is at the top of the list. You could even see the little organisms here inside of the brain. And don't forget, amoebic abscesses from amoebic dysentery does not usually, even though it usually occurs in the liver, here you have an abscess in the brain as well from amoebiasis. And look, it has their little ring sign, isn't it? Like we told you, most of the abscesses do eventually. And here we go, trypanosomiasis, sleeping sickness. Those little devils that you see in the blood film, those little trypanosomes, okay? Basically an African disease in which you're bitten by the tsetse fly. They can also form brain abscesses and brain involvement as well. Rocky Mountain spotted fever, a rickettsial disease. There are other rickettsial disease. Do you see how there are multiple little tiny areas of increased signals? Did you ever see a patient with Rocky Mountain spotted fever? Okay, they have little hemorrhages in their skin because it's basically a disease. This rickettsia basically causes a inflammation around the small vessels. Well, look, not just the small vessels of the skin, but all these tiny little white dots are little vasculitides as well. And finally, even in the filarial worm parasite category, okay, you could see what they call Echinococcus cysts. And those probably are the most interesting of all, because in it, the brain simply looks like Swiss cheese. These are just water-filled cysts. That's why they're also called hydatid cysts, because hyda means water, okay? And this one, you wouldn't even believe is possible, but it looks like just this, like a brain that has some holes punched in it with not much of an increased signal or increased density around it. So these are all diseases which you should at least kind of remember can be associated with very severe and often localized C and S involvement as well. Okay, so I guess you could say we're done, but remember we had a short first part, so I wanted to just introduce you now to what I would normally call CNS2, but this is going to be an introduction to our next webinar when we talk about degenerative brain diseases. But it also is kind of connected to what we just talked about, which were infectious CNS diseases. This is the weird, curious, mysterious family of CNS type of infection, and I'll use that word infection loosely, called prion diseases. Okay, now what does prion stand for? Well, the PR stands for proteinaceous, and I stands for infectious. The thing that's really weird about prion diseases is that they are kind of infectious in a way, but they're not organisms. They're proteins. They don't have nucleic acid. And in human beings, at the very top of the list is a disease called Creutzfeldt-Jakob disease, or CJD. Now, sometimes I heard it called JC disease. They wanted to give Dr. Jakob the first thing. Rather than CJ, they wanted to call it JC. But remember, we have a JC polyomavirus, so maybe they didn't want to get it confused with that. There's another syndrome, rare, but you should know if you ever hear of this crazy Gerstmann, Straussler, Schenker, that's also a prion disease. There is a rare, these are all relatively rare, familial insomnia type syndromes, which are prion diseases. There is a disease in cannibals, or if they still have them around, I guess, called Kuru. You know, cannibals very often ate the brains of their enemies. I don't know if there's any left. I mean, not enemies, but cannibals. There's a disease called scrapie in animals, sheep and goats. That's a prion disease. Minks, those little critters that we kill so women can have expensive coats, they can also have a transmissible encephalopathy. There's a wasting disease in deer and elk. And of course in cows, the big worry when there was a BSE, or bovine spongiform encephalopathy in cows, they were really freaked out as to whether that could involve humans as well, because it's also a prion disease. Now, let's try to explain this as well as we can. First of all, prion disease. A prion is an infectious particle, but it's not an infectious organism. It's an infectious protein. It's a changed protein, okay? In general, all of these diseases we just rattled off share certain common features. The infectious agents apparently do not have DNA or RNA. They primarily involve the central nervous system. Now, there is an accumulation of prion protein when the normal prion protein comes in contact with a prion altered protein. It causes that protein, which is many parts of the body, but most notably in the central nervous system, when a prion protein particle comes in contact with normal prion protein, it changes the conformation, it changes the shape, it changes the configuration of the normal protein, and that spreads to other normal prion proteins. As a result, because this is primarily a central nervous system disease, it produces changes in the brain, in the neurons, in the glia, which we call spongiform. Why do we call them spongiform? Because a sponge has a bunch of holes in it. So normally you see a brain and there's all these little vacuoles inside of it. That would be called a spongiform encephalopathy. Now, these altered prion proteins can not only change other normal prion protein to become abnormal and cause these spongiform changes, but they can be transmitted as well. Now, that's the good news. Here's the bad news. Most documented cases of prion diseases are fatal, and there's no obvious therapy for them, okay? That has not changed in many years. I hope that eventually it is, but right now, this is a normal prion protein. We know where it's made. We know it's coded by genes in chromosome number 20. Okay, we know the exact number of amino acids in it. It's 28. Okay, now for this normal prion protein, which we have in many parts of our body, but mostly central nervous system, when it comes in contact with an altered prion protein, the infectious particle, it causes a conformational change of this shape, okay? And this is the thing which ultimately causes the disease as well. Here, you know, I have a video of it that's explained also in pretty good detail by a very famous neurologist, which you could watch, but we're not going to watch it now. But let's get to the meat of it. It's replicated when an altered normal prion protein comes in contact with an altered one, and then it causes other prions to be altered. Here's another new thing I found last night. These are normal prion proteins. You know where they're made, you know what they are shaped like, you know that they have an amino acid, what did I say, 208 or something like that, 208 amino acids. And now it comes in contact with an altered prion protein. The greens are normal, the red is altered or abnormal. Once it comes in contact with it, it changes it into a red. And then once that red comes into contact with more of its neighbors, it causes more altered proteins, and that's what causes ultimately the spongiform encephalopathy. That's what the SE stands for in bovine spongiform encephalopathy. And this is what it looks like. You could tell, here's a neuron, here's a neuron, here's a neuron, here's a neuron. Maybe these two guys are parts of a neuron. The rest of these are glial cells. But look at the fibrils between all these cells. Do you see how they're filled with holes like a sponge? Well, that's a spongiform encephalopathy, which you could see in basically all of these diseases. But in humans, the primary one is Creutzfeldt-Jakob disease. It's pretty rare. It's only about 1 per million. It's usually in older people, okay? It doesn't occur as, pandemics or widespread. It's basically just sporadic cases. And yes, it's transmitted when an altered protein comes in contact with a person from another person who has it, like you eat their brain, for example, that would cause a spongiform encephalopathy. Sometimes there's been familial cases, but there's no specific gene that you could say causes CJD. It's a rapidly progressive dementia. And what does dementia mean? Well, it means loss of thought. Where's your thought? It's in your gray matter as well, okay? It can also affect the cerebellum, which means it'll produce ataxia symptoms. And it's fatal, okay? Like most of the known documented prion diseases. One of the people, or one of the groups of people that were most afraid of CJD were pathologists. Why? Because when they're in the autopsy room and they got a saw cutting through the calvarium and going into the brain, those little saw chips are like sawdust from the bone, okay? They can actually perforate your skin a little bit. So if you do an autopsy on a demented man who has CJD and somehow your skin is perforated or comes in contact with those flying bone chips, you could get CJD. Of course, there was always a sign in most of the hospitals I've been at warning you about this, but I don't think they have them anymore. So, are we done? Yes, we're done. And when we do our next webinar now, in about 5 days, we'll go into the demyelinated diseases and maybe some of the degenerate diseases. And we're done for today. And I don't feel guilty anymore because now we've gone well over an hour and a half. So I don't have to feel like I'm cheating you of anything. And that means we can deserve to listen to another amazingly beautiful song by Donna Summer.
Let's dance, let's chance for love. Yes, it's my last chance of romance tonight. I need you by me, beside me, to guide me, to hold me, to scold me. 'Cause when I'm bad, I'm so bad. So let's dance, let's dance, let's dance, let's dance, let's dance, let's dance tonight. Let's dance for love. Yes, it's my last dance, romance tonight. Oh, I need you by me, beside me, to guide me, to hold me, hold me. 'Cause when I'm bad, I'm so bad. So let's dance, let's dance, let's dance, let's dance, let's dance, let's dance tonight.
That was pretty much an abrupt ending too. So buzzards, rock on. But if you can't rock on, at least dance.